Oh no, I was just going to say, Manasi, we work with Carriston and the Stanley Research Institute, and I think you're going to speak a little bit about the trauma work.
About the trauma work and also some work that I did with UNICEF, which might be relevant. So two specific things. I thought I'd start with a little bit of background as well. And yes, like Vikram said, I've worked with him previously, known him for a while, has been a wonderful mentor. So happy to be here. And thanks again for inviting me to present, also for inviting me to the game. It's been on my Boston bucket list for a while, so thank you. So just to give an outline of what I'd be presenting today, I wanted to give a little bit of background about some of the various research influences to my work and what the focus of the work is, but speak specifically today on two projects. One focused on mixed methods research for trauma and resilience in mental health and psychosocial support interventions, specifically in humanitarian settings, which has been the focus of my work for a long time now. And second, to talk about some work that I've been doing on evidence synthesis around mental health and psychosocial support interventions, which I think might be relevant here for this group as well. And both of these, I'd love to invite feedback, but also collaboration, because we're trying to see how to roll this out. So for folks who might be interested, happy to talk more. So as Vikram mentioned, I'm currently working at the Population Mental Health Lab, which is over the School of Public Health. Actually, there's a student symposium that's happening tomorrow, so happy to share more details if anyone wants to come attend. But I also work at the Stanley Center, at the Broad Institute, and these are broadly some of the projects that I'm leading the scientific evaluation of, and a lot of our work is in sub-Saharan Africa, which is where a lot of my work has been in the past, alongside work that I've done in South Asia. And we're looking at several studies that look at trauma and PTSD, but within the larger scope of other mental health conditions as well. And we're also doing some intervention work, specifically in Kenya, using the Stair Coach app. I also have some work in Mexico and a lot of capacity building work across these studies and fellows from the different countries. And yeah, so a lot of this work is involved research, capacity building, but also dissemination across various channels. So I just broadly wanted to cover some of the research influences, which have been in various buckets. So I do have a background in clinical psychology as well, which was work that I did in my undergraduate and graduate, specifically using CBT and family therapy. But I slowly made my way out of clinical psychology, and I'm an epidemiologist by training, but these are some of the other influences as well. I also adopt a rights-based perspective to a lot of my work, and specifically worked with the MHPSS intervention guidelines, which I know a lot of you might be familiar with, but also some work using the UN Convention of Rights of Persons with Disabilities to see how mental health care can be integrated into sort of laws and policies as well. And then this is work that I did with Vikram some maybe 15 years ago at the Public Health Foundation of India, where I was working on universal health coverage for India, but also working to sort of build up the Center for Mental Health and several projects that we had under there, including work on Disease Control Priorities Network and SHARE and other projects. After which I moved over to the Harvard School of Public Health. Specifically, that's where I done my PhD in epidemiology and social and behavioral sciences, but also in global health. And my focus has been on mental health in humanitarian settings. So, in the last about 12 to 15 years that I've been associated with the Harvard School of Public Health, these were some of the partners that I've worked on in various studies, some studies in Sierra Leone and Liberia looking at trauma for post-conflict factors, but also the Ebola epidemic. but also looking at work in DRC, Ethiopia, Somalia, around gender-based violence, around peace-building interventions. Happy to talk more about some of these, but yeah, I'll be focusing on one specific aspect of this today. And then did my postdoc and some work after that at the Harvard Humanitarian Initiative, which is also focused on work in DRC around trauma. And it happened to also be during the Ebola outbreak, so we did some health system strengthening work. So I'll be talking a little bit about some of that work in humanitarian settings, but also some of the global mental health programming work that I did after my postdoc for the last 5 years or so with UNICEF across the Office of Research, the Evaluation Office, and the East Asia and Pacific Regional Office, because this has actually been very interesting and I think impactful work. So I'd love to share how some of these tools can be used specifically for priority setting and evaluating the evidence around mental health and psychosocial support interventions. These are more focused on youth, so children and adolescents, but have applications elsewhere. So the motivation for a lot of this work is, we know that there is a growing need for mental health care in humanitarian settings and in low resource settings. There's more and more data about, this is just one slide on displacement that's caused by conflict and violence, but also by disasters and climate change. But there are many other factors that you can see to evaluate the impact of humanitarian emergencies. And as we know, every day, complex emergencies are just sort of, increasing in scale and in their impact. There's a lot of evidence around the gap for mental health treatment in low and middle income countries and humanitarian settings. There are also a lot of challenges of doing this work in humanitarian settings, around migration, around not having a population that's fixed, around issues of identity, issues of competing resources. And this is something that I've spent a lot of time working with different agencies, trying to figure out how to really best optimize care. But one of the things that has been a theme across my work is really understanding how you can culturally contextualize both your measures and interventions and what work needs to be done to adapt this. Because we do know that as much as you can respect cultural beliefs, utilize local resources and strengthen community support that helps to build engagement, but also sustainability and acceptability of care, but also, yes, build local capacity. So that's been a big focus of my work all along. So there are 3 strands of research that I focused on. Today I'll be discussing one project that I'm doing on the first one, which is around how we measure and culturally contextualize mental health symptoms. Specifically, I've been doing a lot of work on trauma and resilience and coping. And how do these constructs vary across population groups? So something that might apply in one setting might not apply the same way in other settings. So how do you really adapt measures for that? The second strand of work has focused on risk and protective factors using a social determinants of health lens. And I do a lot of work on mediation and moderation analyses around this work. I'm not going to be focusing on that today, but happy to talk more for others who are interested. And then finally, I do a lot of work on mental health and psychosocial support interventions in these settings. And I'll be talking about some of the evidence synthesis work, but there are other interventions that I'm working on or leading, specifically around peer support, around climate change and mental health. Again, it's a housing social support intervention. So happy to talk about that at another lab somewhere in the future, but today I thought I'd focus on the evidence gap map. So first, I'd like to start out with this project, which is, I've done several studies which have looked at mixed methods measurement research, but how you really understand cross-cultural experiences. And at the end of this, I'd like to invite feedback, but also potential ideas for collaboration on a new study that we're doing. So the motivation broadly for this is the importance of understanding the context. And any concept that you work with has to be contextualized. This becomes really important, and we'll see why here. So this is some of the work that I've done in South Sudan, and happy to share some of these publications where we looked at, it was a large study. This was immediately after South Sudan became an independent country. It's the newest country in the world. It was during the war. And we collected a lot of data on various measures of gender-based violence, of peace and security, but also trauma and PTSD. And this particular study looks at how we measured trauma and PTSD in this population, but also where people go to seek care. So usually with a lot of the adaptation work that I do with measures, I try and do a really thorough psychometric validation. And this is just giving a snapshot of, we use the Harvard Trauma Questionnaire, which I believe is actually this work was led by the Harvard Program on Refugee Trauma, which is also here, and validated it, but you can use various methods, and this is just giving a snapshot, but it gives you an idea of what experiences people have, what items are endorsed, but also can help with things like scale reduction, especially when you're working in a setting where you're collecting a lot of data and there's a lot of participant burden on collecting all of this data. So if you want to reduce your scales, you can use methods like item response theory and differential item functioning. Happy to talk much more about this, but this was a study that was done with USAID, which now, of course, RIP. But also we worked with people who were in this UN Protection of Civilians campsite, so they were internally displaced, and also had looked at PTSD and perceived levels of security. But with this, we found that large percentages of the population had said that they experienced a lot of destruction of property, a lot of witnessing of family members being killed, exposure to war-related fighting. But on further analysis with this data, also found that there were specific items that were more sensitive to the underlying trait. And it's an interesting field and debate around how you can do this kind of work with checklists versus scales. But for mental health symptoms, this is really helpful to see, for example, PTSD, which specific items are more representative of the underlying trait. And that's some work that I'm also doing currently. But you see that things that were highly endorsed might not be the most sensitive. So for example, the highest curve here tells us about witnessing someone's family being killed is potentially really traumatic for them. So what can we do with this data? This is something that we would want to retain if we're asking more questions during assessment, during clinical work as well. I also saw that there were differences in how population groups understand or report different kinds of trauma. So we do know that there's a lot of sex differences in how people report trauma or experience certain events. And doing some work with differential item functioning across these, we found that some of these are much more salient for men, which is in blue, versus women, which is in red. And if we're doing if we're sort of having clinical services that we're giving out, then they should also be reflective of specific experiences that men and women might have had separately. So it could be gender-based or gender-sensitive measures, but also services. And then we also found that even though we sort of asked some of these questions and there were clinical care services that were being provided, people actually wanted to speak to family members and religious leaders and traditional leaders. Again, goes back to the importance of engaging with the community members and locally contextualizing things. So now I'm going to move to some of the work that I did in Liberia, which was kind of taking this, psychometric work that has been done and really thinking about how Western diagnoses might actually differ from local conceptualizations of mental health. So one example is actually from ethnographic work and anthropological work that was done by Sharon Abramovitz, who I believe worked with Arthur Kleinman as well. And it was interesting. So I spent quite a bit of time in Liberia, and I remember this came up a lot as well, where people talked about stress that they experienced as a physical symptom of a softness in the head. And if you were just coming in from the outside, you would not know that this is what you were looking for. But it's really understanding some of these factors that helped us understand, okay, if a doctor's going in, if someone's doing clinical assessment, they need to be looking out for these factors, which might not have a physical manifestation. So this is work that I did on trauma, but also around coping, which I'm happy to present another time, some of the coping mechanisms that we found. But really what was interesting here was that we did a lot of key informed interviews and focus groups and found that there were certain types of traumatic experiences that were described by people. In this interview specifically, we asked people to talk about what they'd experienced, someone they knew had experienced during the war, and what factors led to suffering and what factors led to recovery after these experiences. So people talked about some things that, this just illustrates how if we were just using the questionnaire that I had described before, we would not have captured a range of things that people described very specific to that context. And then this was used then to develop an intervention that targeted things that people described in some of their qualitative interviews as well. So similarly, some of the work that I'm doing right now is, so this is a study, it's called The Genetics of PTSD in African Ancestry Populations. It's a large scale genetic study, but I lead a lot of the phenotypes work, which is focused on some of these measures, but also the qualitative work. And I'm involved in some of the intervention work as well. So we use the life events checklist for a lot of our studies, and the mixed methods work I've been leading is focused on analyzing some of the open-ended questions that people answer. So if you see out here, people endorse a range of traumas that they experienced, and these closed-ended measures will have a fixed set of things that they ask about. We also ask people about other experiences. And across the different studies, what we've seen is that these other experiences were highly endorsed, but also labeled as their worst traumas and the ones that were most associated with PTSD in this population. So initially, we just asked people to say other, but then we found that this does not really tell us more about what that other is. So we started doing open-ended questions. And I've spent quite a bit of time just analyzing these open-ended questions, and these are the kind of themes that were coming out. So we had a lot of themes around grief, around unemployment, around COVID, relationship issues, and I'm going to go on to some of these more specifically, but I also just want to highlight one thing that I was saying, where I'm now doing some mixed methods analysis and some quantitative analysis with this as well. But one thing that was really interesting is that, so the PCL is a measure of PTSD. And usually, the scoring says that you could look at scores below 33 as low PTSD symptoms, and then scores above 33 as probable PTSD symptoms. There's also new research about this scale potentially measuring complex PTSD, which is a 51 or 50 and above, and that's really severe PTSD. So people who endorsed these other traumas that were not captured by quantitative measures really talk about how it really goes to show you that there's severe PTSD that people are experiencing because of these symptoms. So we're delving much more into this data. And the methodology that I've used for the qualitative analysis is with a group that's been coding the data, and we've been doing this in an iterative way. We're also incorporating AI, so using Lumivero into coding and seeing how this could help with rapid qualitative coding as well. and are doing some grounded theory and thematic analysis right now with our colleagues in Africa. So this is just kind of, throwing out some of the codes that were coming out, but you see there were a lot of really interesting codes around childhood trauma, around mistreatment. People talked about specific things like, I don't know if I see it here, but seeing dead bodies and how that something as visceral as that could lead to a lot of trauma and PTSD, or abuse that they had experienced. People talked about domestic violence, again, which is not, it's captured in studies that are specific to domestic violence, but not in a lot of these checklists. So this is kind of a plug for doing mixed methods work, especially in other contexts where you're trying to use measures that have been developed maybe in the US or other settings. And then this just kind of brings me to the process that I've been following for some of the other work that I'm doing with measures. We've just submitted a paper on validation work that I've done with the PHQ-8 in Madagascar. This is a study of climate change and mental health, but no one has really been looking as much. I think the PHQ hasn't, or there's been no measure of depression that's been validated in Madagascar. So it was really interesting. We used free listing and key informant interviews to identify local conceptualizations of depression and how they mapped onto existing items from the PHQ, and then also added that and used the adapted measure and tested it out. And now we're using that in our intervention studies as well. So this is some of the ongoing mixed methods measurement research work that I'm doing. I've talked about some work with the life events checklist, but we're doing similar work with other measures as well. There is interesting work on resilience with the post-traumatic growth inventory that I'm doing, which I'm happy to talk about. But I actually wanted to now just bring up this one study that I've been involved in, and we were actually there earlier this year in Goa. This is for the global collaboration on traumatic stress. And I'm co-leading one of the work packages, which is looking at mixed methods, work to culturally conceptualize trauma and healing across different populations. So the name of this project is Matrix. It's called The Many Faces of Trauma and Recovery Around the World. And it's really a global project. I'm happy to share the website where you can get more information about it. So broadly, the study has two aims. One is to determine cross-cultural variations in conceptualizations of trauma, traumatic responses, and healing. I'm particularly interested in the healing aspect of it because one thing that I've also seen with this kind of work is how people talk about help seeking in different ways. People talk about their coping strategies in different ways. People talk about where and how they go to seek help, what sort of social supports they have. And here we've also taken a social ecological approach to see what individual level coping mechanisms people use, what social and structural level coping mechanisms people use. And then secondly, we're trying to explore factors that promote healing outside of what these coping mechanisms are. So this is broadly, the work package, which is using semi-structured interviews and focus group discussions, but we're also working, this is part of a larger project, which includes AI-assisted systematic reviews, and then we're doing surveys across countries, and some ethnographic work, eventually leading up to an intervention that combines all of these findings. So here we wanted to explore cross-cultural conceptualizations of trauma and healing using the cultural formulation interview, which I'm happy to just show briefly, and also the global psychotrauma screen. Again, it's a screening measure that can be used to capture both traumatic stress, but also complex PTSD, dissociative symptoms, coping strategies. And yeah, so this is a global psychotrauma screen. it's a 17 item screener. I've been doing a lot of work with screeners as well and seeing the sensitivity and specificity of it. This one seems to be a really good one to capture some of these symptoms. So we're trying to validate this. And the cultural formulation interview, it's a lot of things. So, this is just to throw it up there, but asks questions on things like help seeking, what the cultural definition of the problem is, what causes people attribute to this problem, what their preferences are for help seeking, what barriers there are for help seeking, what their support mechanisms are. And we're doing some work around adapting this. So this is something that I'd love to kind of open out as we're trying to see if there are people who are interested in or have sites that they want to collect data using these measures and be part of the larger study. So I'll stop here for a second before I move on to the next part of this.
So
Yeah.
when you say interested, what do you mean? Collaborators? And is there funding on it, or they have to do like the grants for funding?
We're writing grants right now, which we'll be submitting this year. So if there are people who are interested in being part of the grant funding, because this is truly a global collaborative call.
Oh, nice.
But if you have a country and area that you're working in, this might be something of interest, then please feel free to reach out as well. But so I wanted to open up to any questions before I move on to the interventions, please.
So I was interested, the CFI reminded me a lot of the explanatory model interview. The questions look very, very familiar. That was an interview that was developed by Mitchell Weiss, who used to be a postdoc here in this department with Arthur Kleinman. And I wondered whether you'd seen that. This is called the EMIC. And then back in the mid-90s, I had developed a short form of the EMIC, or not, it wasn't the EMIC, but a short form of the explanatory model interview, along with a colleague in London called Keith Lloyd. And that was called a short explanatory model interview, which we then used in Zimbabwe and used in India as well. But basically, all of this is derived from Arthur Kleinman's original work on the illness narrative. So the question looked very similar, and I wondered whether this was a kind of another iteration of the same idea.
Yeah, so this one is interesting because I've done a lot of qualitative interviews as well, but I found this quite comprehensive. And one thing that I actually found very useful is they have a lot of supplemental modules to the CFI, which is for specific populations. So for children with disabilities or for people in conflict, for gender-based violence. So I think there's been a lot of adaptation work that's been done on specific areas and questions and populations, but I would love to actually look up the EMI and see, what questions were there, or if you found particular areas that might have been interesting or challenging in actually using the EMI. I think one thing that comes up with all of this is it can be so long. So doing this kind of work, it can be taxing for people, and I'm always trying to not re-traumatize people with the work that we do. So this has a lot of positive factors as well that's built in, but yes, curious about the EMI, and so I can look that up as well, but thank you.
Yeah, Vikram, to your point, the CFI is actually a part of the DSM-5.
I know.
And so this was included in 2014. And one of the main people who worked on the CFI was actually Devin Hinton. So again, anthropologically trained and drew a lot from the EMIC model, etc. Mitch Weiss's interview guides when putting this in. And it's long form because it's meant to be for clinical intake interviews by psychologists, not for research in the global health space. But I think it's really similar as well to the EMIC. And Manasi, I really enjoyed your talk. It was so interesting to hear about all the trauma work you're doing and so many amazing parallels, because I also use mixed methods in the research that I do. One thing I'm curious about, you have such a breadth of experience with the number of settings that you've worked in. And I'm really kind of curious if there's certain, I guess, first principles that you might know or have sort of develop some sort of solidity in, even if it's just by experience. But I'm like curious about what are some of the common cornerstones around what people really yearn for and need in trauma-informed care that pervades cultural differences and local differences. Like, what's your instinct on that?
That's a really good point. And it's one that's also, it's kind of the motivation behind this work, because I don't know if there's one specific thing, but I do think one thing that's come up around collectivist versus individual sort of cultures is the role of support systems, the role of family, the role of community. So a lot of the work that I've done in community-based participatory methods, or using human-centered design methods, for example, has also gone in and done a needs assessment on what is important. So again, where people seek help, who gives them the message? So, that becomes really important. It's who do they trust? So where does that trust come from? Where people find support, where people are, what their immediate needs are. Because in a lot of these settings, where people are just first looking at basic housing and shelter, if you go in and are wanting to do all of this, it's not going to work unless it's integrated within some of the other systems as well. So I think that's been a cornerstone of some of the humanitarian work, is making sure you're then coordinating with agencies like WHO, UNHCR, others who are actually giving out care. Otherwise, it's not going to be funded, it's not going to be rolled out if it's not coordinated in any way. This is a big part of some of the successes and challenges with the work at UNICEF as well, was mental health is such a cross-cutting area. So really seeing where it fits in. It's very political as well. So trying to see if you can meet the different demands. So I think that is one thing that I try and do, is working both with who's giving out the care and meeting their needs and priorities, but also what people might be more interested in, how we can work with family systems. This is why taking that social ecological systems approach is useful. But people really talk about things like death and grief as a big, traumatic experience, more than some of the, unless you're actively in a war zone, in some of the post-conflict work. I think our assumption is that some of the bigger traumas or stressors have to do with wars that happened in the past, but it's actually more current stressors, and that's one that gets missed quite a bit in some of these studies. So, yeah.
That's a great observation. Thank you. Sorry, one other quick question. What are your thoughts on social interventions when it comes to trauma? So I'm not talking about like social work interventions as we were describing earlier, like cash transfers, things like that.
Yeah.
But for a long time, I've been thinking about how, it's like, I don't know, there's a person who has a traumatic experience and they're having a normal reaction to very abnormal circumstances, but the social world around them may not understand that or see that or respond to them. And shame is such a big part clinically of like how trauma impacts people, right? And their psychopathology. I'm just curious what your take is on, let's stop treating the traumatized individual only and then start actually socializing people in communities and their families about what it means to be a trauma-informed bystander, support system, this, that, and the other. What's your view on that?
Yeah, absolutely. There's been some interesting work around this. For example, in Sierra Leone and Rwanda, there was an intervention called Family Talk, which I think some people might know about. It was roughly translated from Creole as family talk. So it would bring together communities, but a lot of times people understand that in a war situation or in some sort of an emergency situation, which a lot of countries are facing now, everything gets suspended. So it's not, business as usual. A lot of people are forced to do things they don't want to do. And then after that, perpetrators and victims have to live in the same community. So a lot of these social interventions were focused on actually bringing them together and having open dialogue around atrocities that might have happened, having forgiveness circles, for example. So there's a lot of work around forgiveness as well that's been done in some of these contexts, and forgiveness-based interventions. There are family strengthening interventions as well because of the intergenerational transmission of trauma that also happens. So there are some of these social interventions. I'm now doing some work around housing interventions for the impact of climate change on mental health. And that's a whole other area that's really interesting. And we're trying to see how, especially in extreme heat, domestic violence and interpersonal violence might be aggravated, and what some of these housing interventions using cool roofs might have an impact on PTSD, trauma, interpersonal violence as well. So I think it really depends on the issue and how you can target that, but yeah.
Do you want to finish the rest of your presentation?
Absolutely.
We could.
Yes, so the second part, which I just thought I'd do more of an interactive thing, is some work around this evidence gap map that I developed at UNICEF. So again, some of the broad frameworks that I've used have been around looking at social ecological models, especially for children and young people, the life course perspective, and the social determinants of health models. So I'm happy to also share some of these publications where we reviewed various risk and protective factors across levels of the social ecology of the child, but also different developmental stages. And then when you go on the publication, you can kind of actually click on each of these and see which ones are relevant and what studies have been there across these various factors as well. But drawing on some of this work and using the continuum of care model, I wanted to highlight this one particular project, which is an evidence gap map for mental health and psychosocial interventions for children and adolescents, young people broadly. And this was a lot of work, but it's a really interesting and interactive tool where we looked across domains and looked globally at all low and middle income countries and the evidence on what interventions are there for various conditions, various age groups, and various subpopulations. So let me stop talking and start clicking on this thing to show. Okay, so this is the, how can I change the window to, is there a way that I can
exit out of presenter mode and then
okay, you should just make sure I can. So I think, can you, okay, perfect. So this is the tool, and there's all the reports where you can see this as well, but if you go on this, so we looked at individual and family-based interventions, school-based interventions, community-based and digital interventions. This is again also informed by some of the work I've done around defining what platforms there are for interventions for children and adolescents from the literature, what conditions were really salient, what age groups, and what risk and protective factors. And then on these, you'll see different kinds of interventions as well that we've evaluated. So it has systematic reviews and meta-analyses, but also primary randomized controlled trials, quasi-experiments, and then mixed method studies. So you can, and some of the conditions we've looked at are PTSD, depression, anxiety disorders, conduct, and then ADHD, but also positive mental health factors as well, like functioning, well-being interventions, coping interventions, and early childhood interventions as well. So social emotional learning, these are outcomes here, these are platforms, and then you have promotion, prevention, and then treatment interventions. So you can also filter here and then pick the country level that you want to look at, the region, whether it's males, females, others, age group, intervention format, and then we had specific subgroups as well that we tagged. All this was done with a peer reviewer, and it was done with Cochrane and Campbell collaboration, and we looked at specific countries as well. So just as an example, if I pull up, late adolescence interventions in low and middle income countries, and then updated. So this will start pulling this up, and then so you click on this, and you can see all of the information about each of these studies, including a summary of what the findings were, but then also we also did some reading around the evidence as well and some grading. And this is something that we're updating as well. And broadly, so you can kind of go through each of these by going back to the presentation. So this was done, there were about 63,000 studies that we found when we first started. So it took a lot of screening, but we used AI-assisted selection and screening and data extraction. It's probably been updated much more now. This was done about 4 years ago, so I'm sure the technology has evolved quite a bit. But we eventually had about 7,000 studies that we screened, and then looked manually at the almost 3,000 studies that were eligible, and finally got a sample of about 700 studies. So there was a lot of narrowing down the scope, but this was really comprehensive. And there were some broad findings, but feel free to go to the reports as well. And broadly, we see that there were a lot of interventions that were treatment focused from these studies. This is giving an overview of the literature that's there, the evidence that's there. Mostly interventions in early and late adolescence. Again, a lot of treatment interventions in early and late adolescence. We had a lot of school-based interventions that we found literature on. And then you'll see a map with where some of these studies are coming from. A lot of them were from India and China, so that's encouraging. Again, the scope was focused on low and middle income countries. We thought about including high income countries, but it would be too much, so next time. And then depression was the one that we found a lot of the evidence on, followed by anxiety disorders, but also well-being broadly and post-traumatic stress disorder. Again, the operationalization of things like well-being was fairly challenging, but we looked at other definitions that have been used by WHO and others. And then this work has then been applied in various ways. So some other work that I'm happy to share as well. We did with the UNICEF Office of Evaluation, which was using this data and then mapping and selecting what some of the most innovative and transformative and scalable interventions were, and working with different country and regional offices in priority setting and proposing impact evaluation study designs for how this could actually be funded and also carried out. So yeah, if you go to this link, you'll see all of the data and the documents, but I thought I'd just open up and see if people have questions about this.
Well, thank you, Manasi. That's really incredible. This kind of resource is just so special, so precious. I mean, because is it a living review? That means it's being constantly updated?
That was the plan. So I'll have to check. I think 2023 was when there was going to be another update. So, but then it takes almost a year or 2 years to do this update because it's comprehensive. So there should be another one coming up this year.
Yeah, and I'm assuming these AI techniques can now allow you to do these in an automated way, with some human kind of checking for for false information. But I'm assuming a lot of that, because there was a time when reviewing the literature was extremely it was the most painstaking research method of all. But I'm assuming AI techniques can now do a lot of the initial screening.
Yeah, absolutely. Even this, they were able to do it, but I just remember poring over all of these Excel sheets for days and hours and weeks on end. So yeah, I think I'm sure now it's just much more advanced, but even then, I think it's more about setting your screening and selection and inclusion and exclusion criteria really well, so that AI can replicate it. So it would be this iterative process of AI doing 5%, then 10%, then building up to be able to do more. And then you have to do some human checking around it.
Thank you so much. I learned a lot. Two quick questions. One is about the first set of the studies. You talked about, the cultural context, and I agree it matters. What do you think about the concepts, like, having something soft in your head? How do you map that onto what we know in mental health? Is there a way to connect those dots and say, maybe what you're saying is some, different terms, but the manifestations of it, sound like a depression in a way. And the reason I ask that is in terms of grant writing, how do you make it a grant to say, you know what, we're going to focus on something soft in someone's head? Of course, you can't do that, but how do we make that connection back from the context into what we know in our field? But then, too, this one should be easier. Are there specific tools for AI to do these reviews? Yeah.
So, two, I will say quickly, this one we use Epi Reviewer, which is the tool that's used for evidence gap maps. So we work with the Institute of Education and 3IE, which is based in London, and they do a lot of evidence gap maps and reviews as well. Still had to do a lot of work around this, but Epi Reviewer is good, and I think it now should be built in, but we had someone who was a machine learning expert in our team who actually set up the code and trained the algorithm. We're now exploring that with our qualitative data as well, using LLM to do AI assisted qualitative coding as well. But to your first question, I think some of these things, so a lot of the work that I'm doing now is looking at the association between trauma and chronic physical conditions. And there is something to be said about psychosomatic symptoms. And so this, open mole is one that's been described as, again, I think we need much more to really validate and confirm that. But when doctors talk about not finding, a physical sort of consequence of that or symptom of that, but this is something that people are reporting, there's really something salient to be said around that. And I think for grant writing, that's an interesting way of putting it, is there are psychosomatic or there are manifestations of mental health symptoms that we might not find with Western measures, for example. And that's how I've also package some of these grants, is the importance of really understanding what people identify as important or what people identify as their own symptoms in their culture, and there's no other way of capturing it. I also go back to Brene Brown's work on cultural conceptualizations of shame, of guilt, and things, right? People have different ways of talking about it. So I think some of this work is important to actually understand that. But there are ways of tying it with free listing exercises, for example. We can say, so we did that with Madagascar. We asked people, talk about what do you feel when you feel sad? And people talked about different descriptions of their symptoms, and it roughly mapped onto symptoms or items from the PHQ. But there were some that were different. So there is that mapping that can be done as well.
Laura?
Thank you so much. This was really fascinating. Every time I hear a presentation on this topic, it just makes me think about the huge gap between practice in this area and research in this area. And it makes sense why there's so many different priorities. Like with this, there has to be an emphasis on generating new knowledge if it's any kind of research project, but there's so many organizations working in MHPSS, and it's only interventions and not research. But there might be a lot of those interventions that are actually, I guess they think about innovation in a really different way. And if there is something that might be innovative and actually really useful on the ground, but it's not being set up as a research design where you can actually test it, how can you incorporate that kind of knowledge when you're just thinking about recommendations for countries?
Yeah, no, exactly. I think that's why this kind of work is also important for the interventions to be informed by, if it's evidence informed, but also culturally adapted to address symptoms that people might be reporting that might not be the same as, depression or anxiety symptoms that we find in other countries. So, looking at those in between, I think there is growing work on this. I've seen some systematic reviews that have talked specifically around cultural manifestations of mental health symptoms, and that can be used to then match with interventions. I think that's an area of work that would be really exciting, is to see how we can take evidence-based interventions and then match them with local conceptualizations of mental health as well.
I mean, on that point, this issue of the phenomena of mental health problems, it's a very old line of inquiry of medical anthropology. And, I'm sure William, you and Laura are both familiar with the writings of people like Arthur Kleinman, and in fact, a whole generation of anthropologists, the whole writing on idioms of distress and how these map onto Western diagnostic categories. Is a very, very large body of research on this. And it's impossible to sort of summarize this in any one sentence, but my takeaway has been that to a large extent, many of the phenomena are in fact cross-culturally described in grounded work, by ethnographic work. So it's opposite from, using a diagnostic instrument, identifying people, and then asking them what their distress is. Grounded work would be you apply no preset diagnostic categories, and you literally work with, for example, traditional healers. In fact, I did that work in the mid-90s in Zimbabwe. And I remember very, very clearly how I was actually surprised, because I had been heavily influenced by ideas that everything was very different in every cultural group. I was actually surprised by how much was similar. And it was completely contrary to what all my, ideological training, I would call it now, because it was not really what I was seeing in, and I'm not even talking of psychiatric clinics where I was based. I'm talking about traditional healer settings where, I would sit and interview people. But there's no doubt also there are, of course, idioms that you don't see in DSM and ICD. So there's no question that there are also idioms, but I don't think it's true to say that there is no similarity at all. I see it as a Venn diagram. There are some core phenomena. I think those are the ones we should emphasize when we are talking about applying, models, theories, measurement instruments from one cultural context to the other. And then you have to also do the work of identifying locally, in local languages, what are the other idioms that could help you identify people with a target condition. So in Zimbabwe, for example, and this work has continued for more than 30 years with Dixon Chibanda as well. The idiom of kufungisisa, which is thinking too much. I don't know if Ghana there is an equivalent, but this is a very common idiom now. In fact, there's a systematic review on thinking too much that Brandon Coates' group published in Social Science and Medicine some years ago. And they found that this idiom is described in many parts of the world, in Southeast Asia, in Cambodia, for example. So, and it's an interesting idiom because the English translation is thinking too much, which you can see actually has a very strong similarity with what we call rumination. You keep thinking, you don't get out of this kind of negative loop of thinking, and there's nothing you can do about it, and it just gets you extremely miserable. So there's a very clear connection, but there's also a connection with the Western or the modern psychological construct of worrying, and so you could be either of these two. So it's not totally foreign, but it certainly has a lot of validity so in fact the measure that we developed in Zimbabwe, the Shona symptom questionnaire that Dixon uses for all his work on the friendship bench, one of the core phenomena that is measured in that is actually on thinking too much. We don't use anxiety or worrying, we use that concept.
Yeah, I was just going to say similar to that is this work in Madagascar, which is we identified some of these symptoms around jungle Bomare, which is more becoming crazy self-talk, wandering around, but then people also talked about head down, gloomy face. So there are cultural differences. You'll see a lot of physical symptoms that people talk about. So it was very similarly, we found this from some of the qualitative work, but then these can then be added to the core symptoms that you see with the with measures like PHQs.
And thinking too much is there too.
Exactly. So there you go.
I think too much sometimes as well.
I think with the physical symptoms, it's also interesting to think that who is asking the questions, because if the interviews are being in a well-being health setting, it's also frequent that people will talk about the things